Hello, and welcome to this much anticipated webinar titled What You Need to Know About ACGME and ABFM Expectations for a Shift to Competency-Based Medical Education. My name is Jenny Miner, and I will be helping to facilitate today's webinar. This webinar is the first in a series of webinars focused on navigating the shift to competency-based medical education, brought to you by a partnership between STFM and the AFMRD. We hope to see you at the next webinar on January 10th, 2024. During this webinar, please utilize the Q&A feature to ask questions of the panelists. Although you may ask questions at any time, designated time has been set aside to answer your questions toward the end of the presentation. Please join me in welcoming today's panelists, Dr. Warren Newton, President and CEO of the American Board of Family Medicine and the ABFM Foundation, and Dr. KrisEmily McCrory, Associate Program Director at the Cheshire Med Dartmouth Health Family Medicine Residency Program. Dr. McCrory will begin today's presentation.
Excellent. So excited to see everybody and welcome. We're going to go through a series of slides, and we're going to talk about really what those expectations are around competency-based medical education and talk a little bit about kind of core outcomes and competencies. And then Dr. Newton will come on when I'm done to talk a little bit more specifically about some of the ABFM components to that. So, when I first started hearing about the competency-based medical education and the core outcomes, that kind of came out at RLS earlier this year. And then there were these follow-up articles that came out from the Journal of the Board of Family Medicine and the Annals of Family Medicine. And I really started hearing a lot of chatter, both at conferences, as well as in some of the listservs for AMFRD and STFM, really kind of being like, why now? Why are we doing this now? And what about the core competencies and milestones that we've been working on for the last, the last 12 years? Are we throwing those out? And really feeling the pressure the anxiety that people were having about the challenges that we're facing right now as we are going through residency training. We're working with fewer resources in terms of time and money and faculty. We're feeling more institutional demands. We've come through this COVID pandemic and this subsequent exodus of physicians, providers, and other support staff. We've got this increased need for telehealth, and how do we put that into our curriculum? This overall downtrend of our in-training exam scores have been really nerve-wracking for us, and a lot of concerns about medical student readiness in terms of residency training and how do we train up that next generation of family physicians. And all of this is happening in a political climate that's really creating both legal and cultural challenges to how we provide care to our patients and how we educate our residents. So I have definitely felt a lot of anxiety around how are we going to implement competency-based medical education now, and how are we going to start using these core outcomes in a way that's effective. And so I'm really hoping that through the course of this webinar and the resources and additional webinars throughout the year, that people will start to feel that they can manage this. So in response to the call from ABFM and ACGME on competency-based medical education, the STFM created this national task force that's ultimately charged with the responsibility to develop faculty development and best practices for competency-based medical education implementation in family medicine residency. So these are the things that we've been working on. A national guidelines for the implementation of CBME in family medicine. So really a guidebook to kind of help programs know what they can do with terms to evidence-based practice in this realm. And that's just been submitted for publication. So that'll be something to look forward to over the next few months. Presentations from various members of the task force, both at RLS and STFM's annual conference, on a whole bunch of components of CBME and how to make them work in your program. We've got this webinar series, of which this is the first. And in the next slide, I'll give you a taste of some of the webinars that are coming up. Very important, we have the CBM toolkit, including assessment and implementation tools that's available for us right on the STFM website. And I know that they'll pop the link to that in the chat at some point in time. We just got approval for these faculty development delivered workshops where programs can actually request from STFM to have faculty come out to your programs for half days or full day workshops on STFM or on the CBME. And then finally, we're working on a mobile app to help for in-the-moment assessment, because we know that assessment piece has been really concerning for people. So keep an eye out for that. And just a quick teaser of some of the different webinars that are coming up over the year. So we've got about one per month for the next 11 months or so. So certainly these are going to be spots for you guys to get more information, more skills, more knowledge on some of the different intricacies of CBME. So I always like to know who's in the room with me. So we're going to pop up a poll here, and it should come up, and just identify your primary role right now, and then how long have you been in GME, and not necessarily in your current role, but just overall. We'll give that a few minutes for people to get that, and then we'll see where we're at. All right, so good to see a nice mix. So we're really kind of right across the board. We've got a good chunk of program directors, associate program directors, and core faculty. And I like to see that we've got some program coordinators in here as well. And really a pretty even split of experience. So I'm glad to see that. Excellent. So just a reminder of the role, since we're talking about kind of the call from ACGME as well as ABFM, and for people who are maybe new to the GME world. So the American Board of Family Medicine is under the umbrella of the American Board of Medical Specialties, and they are responsible for maintaining requirements related to individual board eligibility. So this is the eligibility for certification of individual physicians. And, you know, they have responsibility and requirements around training time and continuity and whatnot. And they are ultimately the ones that have the call for the core outcomes that we're going to talk about a little bit more down the line. And then the ACGME, which is the Accreditation Council for Graduate Medical Education, ultimately maintains the requirements for program accreditation, and certainly falls under that realm for review committee for family medicine, takes care of kind of those components for family medicine specifically. So different educational requirements, leadership and faculty responsibilities, and ultimately they are the ones that have that requirement with the core competencies and milestones. So we see that core outcomes and core competency and milestones, while they are related, are not necessarily interchangeable, and one is not replacing the other. So just a few learning objectives. What I hope we kind of get towards the end of this is that people will be able to understand some of the differences between the core outcomes and the milestones and how they relate to each other. Identify some of those expectations for the clinical competency committee on implications for implementing milestones and core outcomes beyond just individual resident assessment. So I think there's going to be a lot of things for the CCC to tackle. And then describe the timeline of attestation for the core outcomes that have been proposed by the ABFM so that we know what we are going to need to be attesting to when. So the heart of competency-based medical education really lies in this master adaptive learner. And master adaptive learners are things that I think we've been talking about for a long time. It's not a new concept for most of us. And ultimately, master adaptive learners have this ability to self-reflect. They can kind of look back at their practice, they can look back at their education, and they can reflect upon it. And in that self-reflection, they have this ability to self-assess. They can find those gaps, they can see those places they still need to grow, and they can use that information to self-direct themselves forward with planning, learning, assessing, and adjusting. It's this kind of lifelong ability to learn and grow. And I'm really hoping that, you know, it's one of those things we want for our residents, but it's also something we want for ourselves. Like, this is something we should also be role modeling for our residents. We should all be master adaptive learners. Master adaptive learners kind of have this curiosity, this, you know, what could I be doing better? What could be the things that I could improve upon? How can I make this work more? We have this motivation. We're motivated to not just be in the status quo, and we're motivated to grow. And that really gets to this concept of a growth mindset. We shouldn't just stay stagnant. There's always opportunities for improvement. There's always opportunities to make things better, and that we have this level of resilience. And what that is really just, it's hard to change. It's uncomfortable to change. And I think a lot of people are feeling that discomfort now. So we have this resilience that we know it's hard to change, but we also know it's important for us. So I humbly ask all of you to consider, as master adaptive learners, the following questions as we go through this webinar. What have I heard about the core outcomes that make sense? Be a little curious. Most of us have seen those core outcomes through the different articles that have come out. We're familiar with what's being asked of us. Really think about what does make sense for what I've seen. And then going forward, what am I most concerned about? What are those gaps I'm thinking about? And what barriers do I perceive to implementing this, both maybe for yourself personally as an educator, but also for the program that you represent? And then as you go forward, what do you need? What do you need tools? What do you need for skills? What do you need for knowledge to help address those concerns and barriers? And I'm really hoping as we go through this particular webinar that you will start to see that we have some of those available for you. So competency-based medical education, which is not a new component of anything. We've been talking about it for a long time, but I think people are feeling like, oh, this seems new to me. So there's kind of these 5 really basic components of CBME that I think are really important. The first is this idea of it being an outcomes-based approach. And what that really means is we're starting with the end. At the end of training, what do we want that outcome to be? What is that product we are looking for? And what we're looking for are highly qualified, trained family physicians who can provide a broad scope of care to patients in our community without any kind of supervision. And I don't think anybody's arguing that that's what we would like to have at the end. I think the question sometimes is how do we get there? So this idea, again, that we're starting with the end and our curriculum is going to be based on that. There's this de-emphasis of time spent. In traditional graduate medical education models, there's this assumption that everybody learns at the same pace in the same way to end up in the same place. And I think we all know as educators, that's not really true. So there really is this ask to kind of have some acceptance for an adaptation of pace, intensity, and duration of our learning experiences to really ensure that we have this mastery of all the essential competencies by all of our learners. So it's not enough to have just had time spent. They need to demonstrate this level of competency and trustworthiness. And, time certainly matters. We need to spend time in training, but it's only one feature of training. And so it's this concept that learners learn at different speeds, and there's this need for some flexibility to ensure competency. And this is where utilizing our independent learning programs and our electives are going to be really important. It's going to help with this paradigm shift away from an assumption of competence at the end of a predetermined training period to really observing and qualifying competence of our candidates for specific critical professional activities, which is really what those core outcomes are. CBME is really organizing the curriculum around this hierarchy of competencies, which we have. We have our 6 domains of core competencies, and those really evolve right into our core outcomes. The education is centered around learners. And I think this is something as a specialty we've actually been doing for some time. I think with the implementation of the clinical competency committees, we have really started to engage our residents in their own assessment processes and what we're looking for them. And I think we've already started to put in some of those pieces in place. So this is just an extension of that. And then finally, there's this emphasis on societal needs. As professionals, as physicians, ultimately our responsibility is to society, community, and our patients. And so there really is this need to be able to guarantee that we are providing them quality physicians. That's our job. I want to take just a moment to talk about this, thinking about time differently, and really having this distinction between individual variability in time to mastery versus a variability in duration of training. One of the things that invariably comes up is this idea that, oh, well, if they can be competent sooner, then they should graduate sooner. And I really want to get away from that. Thinking back to this concept of we're really trying to engender master adaptive learners. We want learners who are curious. We want learners who are diving deep. We want learners who are not satisfied to just do the bare minimum. So when you have that learner in front of you and it's like, hey, has this learner met the desired benchmark? When the answer is yes, they have, the question should not be, oh, well, can they leave early? It's no, what can that learner do with the time and resources they have to further enrich their learning? Again, trying to really engender that master adaptive learning concept. And when the answer is no, it's shifting with this idea that the need for additional time is not punishment, but it's a resource for additional opportunities to meet that competency mastery and allows for that necessary flexibility within a normal training experience. Again, not all learners get to the same place at the same time. So just again, thinking about that role of time being shifted from a threat to a resource. So here are the core competencies that we know and love, and I'm not going to spend a lot of time on the individual details of those 6 domains because I know you know them really well, but I would like to spend just a moment reminding people about the milestones, which really are this developmental bridge for implementing an outcome within that competency framework. They are this guidepost along the journey to competence, and I dare say excellence, and to ultimately fully independent practice. We're really trying to get our residents from being these novices who have not had a lot of clinical experience and opportunities to bring them through that advanced beginner to make them competent, because ultimately we want them to be competent for independent practice by the time they graduate. And that proficient and expert spots, those really are kind of post-training, but we're starting that path. And I think one of the things that's really important to remember about the milestones, and I think this was a tendency we had when they first came out, was to try to mistake them for grades or to try to correspond them to specific PGY years. So again, in that realm of CBME, there's this flexibility component, and that may be based on your individual learner needs and characteristics. Again, different learners get mastery in different timeframes, but it may also be based on your program resources. There may be areas of the milestones that you have a lot of resources to put into, so your residents kind of have those experiences to gain that competence early. Or it may be related to your curricular and rotational timeline. There may be certain milestone pieces that the experiences that they're going to have to attain those really happen later in their in your curriculum than maybe in another program's curriculum, and that's okay. So again, looking for this level of flexibility. The focus in the end is on that core outcome, on that what we're looking for at the end, and that the journey may be a little different for each program. And ultimately, that's where some of that flexibility that's come into play with the new ACGME requirements to remove some of the bean counting that's come in place and to really increase the amount of electives that are available. So getting to the core outcomes. So the core outcomes ultimately incorporate multiple core competencies. And I think this is a really important piece for us. The 6 domains of core competency that we are very familiar with, these have naturally evolved into the core outcomes. I think one of the things that came up a lot as challenges as we were learning about the core competencies and dealing with the milestones was this idea of, well, what if my resident is really just competent in medical knowledge and they don't really have this practice-based improvement? Is that okay? And I think what we're really trying to get at with the core outcomes is that all of those domains of competency are really important, and they all come together to really provide the outcome of the physician we're looking for. So these core outcomes incorporate the competencies in a way that capture the broad scope of practice that society, because we ultimately have that responsibility to society, can expect of a family medicine physician who has been entrusted. And you are going to hear this word entrusted many times over the next year. Entrustment is a really key aspect of competency-based medical education. You may have heard this a little bit with the entrustable professional activities that we've talked about in years past, but really is this idea that I trust this resident in front of me with independent practice. They can go out into the world and they don't need me there to supervise them anymore. And that's a really important responsibility from the program director to be able to attest to. So we talked a little bit about how each residency program really exists within kind of a unique context. And each program CCC also operates within that context. So the role of the CCC is really important. And they first came into play when we first had the core competencies and milestones. And ultimately, the CCC needs to be well-versed in the shared standards that are used as benchmarks to assess the residents. And those are rooted in the competencies and the milestones, with this ultimate endpoint being entrustment in the core outcomes. The CCC has to have some transparency in how they identify performance gaps, what residents should be doing to meet the expected standards, because residents need to be able to use that information to enhance their learner self-awareness and develop self-monitoring skills. Remember, we're trying to create master adaptive learners who can self-reflect and they can self-assess so that down the line they can create their own plans. So we're really looking to empower learners to seek direct observation, engage in self-audits, review and synthesize assessment data that they're getting from the CCC to ultimately create those individual learning plans that are being required by ACGME. Additionally, the CCC is going to engage learners in these reflective feedback conversations that are supported and facilitated by your faculty advisors, mentors, and coaches. This really is a co-production work between your learners and your faculty that's deliberately designed to attain a desired educational outcome for your learners, and honestly to get to your desired health outcomes, both for individual patients and populations. Because in the end, if you are graduating highly competent and trustable physicians, that's going to improve the health of your community. And then some other areas that are less individual, but more programmatic that the CCC also has some responsibility for is really identifying those curricular and assessment gaps so the program can address them. Your CCC are the ones that see all the data. They see that, we've got this one kind of level of the milestone that nobody seems to be getting. Why is nobody getting that? And so really coming down to, are we not assessing it correctly? Have we not included it in our curriculum? What is that gap that we need to fill? Again, thinking about modeling that master adaptive learning. What can we do to kind of continue to grow? The CCC is responsible for providing opportunities for faculty development in the context of core competencies, milestones, and core outcomes. There's a lot of things here that the CCC has knowledge about, and they have a responsibility to share that with their faculty so that the faculty can be participating actively with the learners in that kind of co-created learning environment. And then finally, the CCC collects, reviews, and interprets data that is on the individual resident performance, again, to help with those conversations and aspects for engaging the learner, for cohort performance, seeing kind of how classes are working together towards goals, and then finally programmatic progress so that we're continuing to improve our programs. And that's a big ask from the CCC. And I think that's an area where being able to access some of the things in the toolkits and some of the things that are coming from our webinars is going to be really important. So as we think about some of the challenges to implementation and then thinking about how to overcome them, because none of us think that this is going to be easy. It's a big ask from the ABFM. It's a big ask from the ACGME. I really want to, express we understand that. So, first we've got this inexperience with CBME, both from the faculties and the residents. So this is where, I encourage you to use the webinars. If you have the ability to come to RLS or to STFM annual conference, come and go to those sessions that are related to CBME and identifying other learning events to become more familiar with it. We've got this toolkit that's available. The link was in the chat, and it's got a bunch of resources that can really help you learn for yourself as well as for your residents and your faculty. We know that CBME is resource heavy. People are certainly struggling with just lack of time, lack of faculty. So take stock of what you've already done in terms of the milestones. Again, the milestones and the core, the domains of core competency, they really do feed right into the core outcomes. So don't feel like you have to reinvent everything. You've already started to develop some of those pieces. We got back the ACGME protected faculty time back to a more reasonable amount. Take advantage of that. Use your resident learning networks to share your resources. The assessment burden is another one I hear a lot about. We really are in this space where we are shifting away from exclusively expert given grade at the end of the rotation and moving towards this kind of ongoing process of assessment that's geared at engaging the learner to guide personal learning and improvement. I highly recommend, check out the toolkit. It has resources for assessment. Come to the webinar on assessment. The ACGME also has a direct observation assessment webinar. And I strongly encourage you to take a look at all of those. The unpredictable learning experiences, this of course is something we have struggled with all the time, what your learners learn or what comes through the exam room door. So take an opportunity to use those electives in a meaningful way. And remember, electives are just any piece of the curriculum that is not mandatory for all of your learners. So for some of your learners, that's going to be deeper dives into things that they want to experience. For some of your learners, that's going to be additional learning opportunities to be able to demonstrate competency that they haven't yet demonstrated. In addition to those electives, using other work-based assessment tools such as chart audits and 360-degree evaluations and simulation activities as adjuncts to clinical experiences so that you really are giving your residents that real robust experience. And then finally, resident expectations. So really working to be able to reframe resident expectations around time as a resource versus a punishment, understanding those learner responsibilities in CBME, because we're really asking learners to be more engaged in the process. And I think that's going to be something that some residents are really going to strive with and some residents are really going to struggle with. So there's going to be a webinar about engaging residents, and I highly recommend, checking that out as well. And I think, again, just dealing with the fact that different learners have different journeys and everybody being supportive of that. So as I'm finishing up, I really getting back to that, let's all model this master adaptive learning, for our residents, but also because it's good for us. So bring it home, come back and engage with your residents and faculty. How might the core outcomes and the implementation of CBME challenge your program specifically? So you can start to think about those gaps. How could the work you've already done for Milestones help you when it comes to incorporating the core outcomes? Because you've all done a lot of work for the last 10 plus years on this. A lot of those things can translate into the core outcomes. And then finally, what resources will you use to help in the implementation of CBME? We've offered a lot of things in terms of the toolkit, in terms of faculty development and other places. Please take advantage of those things as well. Got a few references. And then I'm going to turn over to Dr. Newton, who will go over the pieces from the ABFM specifically. Thank you.
And Mary, I think you wanted to say something.
Thank you. I'm Mary Theobald with STFM. I was just going to respond to one of the comments that had come in about the mobile app specifically. The comment was, if the mobile app integrates with the major platforms such as New Innovations, this would be amazing. And I did want to let you all know that we are working with New Innovations with their existing mobile app, and the assessments that we're working on will be within that mobile app, so that programs will be able to pull reports through New Innovations. We also are talking to MedHub. We're not quite as far along in the path with them yet, but anyway, that's the direction that we're heading. And we do have several other questions that we are going to get to those, but that was the one I wanted to respond to.
Thank you, Mary, and thank you to Kris and to STFM for kicking this off. We really appreciate your leadership. So my name is Warren Newton. I'm with the ABFM, but I'm also a recovering program director and a recovering dean. And it's a pleasure to be here. What I want to do is lay out the rationale and first steps for competency-based board eligibility. I've sent out articles that I think will articulate the thinking of the ACGME and the ABFM in terms of core outcomes, our policy with respect to competency-based board eligibility, and a recent article about what assessments our residencies are currently doing. Next slide, please, KrisEmily. Probably the most important thing for me to say is thank you to you all. There's a whole lot of people on the webinar, and you're contributing, and all of your work to contributing to the future of our specialty. I know that this is at the end of a recruitment season. All things drop during the recruitment season. And I know also that each and every one of you is trying to rebuild your practices and your residencies post-pandemic. So thank you for that, and thank you for all you do. Next slide, please. I think it's really important as we think about it, before we get caught in the details, is to remember why we are doing this. And it's because the system is broken. Most family docs don't need to be reminded by that, but let's remember that the life expectancy in the United States started to drop in 2014, and it sped up during the pandemic. And it's not just one disease, but all diseases. And this is on top of a 30-year decline in the relative performance of the US compared to other affluent countries. The slide on the left, and some of you have seen this before, kind of illustrates the difference. So the bottom line is that for the United States, for almost all diseases, for all ages, we perform much more poorly than the rest of the developed world. The particular slide on the left has to do with the likelihood of survival past the age of 50 for women in the United States. US is the red dots, gray are all the other affluent countries. You can see that we were bottom quartile in the 80s, and we've gradually not kept pace, and the gap is widening. And all of this is because before COVID demonstrated again that care is unequal. Next slide, please, KrisEmily. So my estimate is that about 5,000 diplomats and residents have participated. We're at our 4th year in the residency redesign, and all of you are aware of that. And as of July, we had to move forward. What's key is to remember that there's a number of different things that are in residency redesign. It's practices the curriculum. It is engaging with communities to address disparities. It is building residency learning networks and providing flexibility for residencies and residents. It is implementing competency-based medical education and creating and building time for faculty to do this work. 2 points I'll make. First is that CBME is a big deal. It's a big shift from hours and years and months to whether or not somebody is competent. This is a big change. Second is it's only part of the package. Let's remember that it is a means to the end. It's pedagogy. It's how we get to the outcomes as we try to change care. We family docs think that well-trained family docs can make a difference in trying to heal our healthcare system and heal our communities. That's why we're here as we go forward. Next slide, please. So how do you go from this set to actually implementing it on the ground? And as you know, the RC guidelines came active in July. Like all good educators, we start with the end in mind, as KrisEmily had said. These are a set of outcomes that were based on what we as a specialty came together and defined, the EPAs, or entrustable professional activities. This was about 8 or 9 years ago. And then it's a revision of them, and it was driven by the review committee, the ACGME review committee, and the ABFM with input from all the family medicine organizations. One of you in the chat asked, well, what's the difference between core outcomes and EPAs? They're the same. The EPAs, we did a survey last summer of program directors, and we became pretty impressed that there was a lot of confusion about what was meant by EPAs. So we basically rebranded them and called them core outcomes. But as KrisEmily said, the issue is entrustability. Do you trust this resident to take care of a member of your family? There are 12 of them, and they represent the shared mental model that both the ACGME and the ABFM are using to move forward. For the ACGME, it's how they redesign the informatics. So we think over the next 3 years, there'll be progressive changes in what you need to submit through web ads, but also we want to change the resident and faculty surveys so that they're more useful for programs and for us, for the RC. And for us at ABFM, we use these core outcomes to think about where we wanted to go with respect to board eligibility. Next slide, please. So what we decided to do, and as all the program directors on this webinar know, we currently ask every program director in June to say, does Jane Doe, this resident, has she finished residency, and is she ready for autonomous practice? We want to extend that logic to say, has Jane Doe finished residency, and is she competent in these areas? Using those areas, the core outcomes. We are assuming that the CCCs, the clinical competence committees, will be involved and will support the program directors. In talking with the community last spring at RLS and afterwards, there was a desire to phase it in, so we spread it out over 3 years. And by 2027, we'll ask every program directors, again, backed up by their CCC, to say this resident is competent for all core outcomes. This represents our promise to America. That is, if you employ a family doc or they get into practice, they'll be able to do all these things. Next slide, please. So I'll go into a little bit of detail for 24 so you understand the rationale. The following years are in the articles that we published in June and that you got. So for each of these years, there's 5 core competencies. Let me explain a little bit about why these 5, which is a very reasonable question. And in the run-up to the final pathways, there was the final RC requirements. There was a lot of concern in our community saying you're doing away with a full scope of care because you're saying you don't need as much month. How many months or hours? You're saying it's less important. And to which our RC in response was, no, we are still expecting competence in these areas. We're just giving you more flexibility in how you reach it. But because of that concern, we made prominent in this first year some of the acute areas, the broad scope of care. So for me, the questions are, can you look at a sick patient in the emergency room, the hospital, and manage them and diagnose and treat them? For a sick child, will you recognize the child that is septic? Those kind of core scope of practice are embedded here. There's also the kind of foundational elements of moving forward. Competence in communication, professionalism and trustworthiness. Those are things that are going to drive development over time, and we want every resident and residencies to be able to assess them to begin with. And then there are personal physicians, and you'll note that there's an element of personal physicians in each of the years going forward as we broaden those out. The point I will make here is this is the other discussion that we had last spring, which is what are going to be easier to do in this first year? What assessments are easily available? So we think that many of the assessments can be done through current rotation. It's like what KrisEmily said. We're already doing a lot of this. The art is sort of tweaking them, emphasizing behavioral issues, the actually core behaviors you want, that sort of thing. But there are also other structures that many residencies have which they can convert over to this kind of competency-based assessment if they're not already there. But we think, in talking with a lot of program directors, that many of them are already there. Next slide, please. I think a really good question is, where are the assessments going to come from? As you can hear, one of my bits of emphasis here is adapt to what you already have first, and then add things on. The perfect is the enemy of the good. Being simple and practical and scalable are key. As KrisEmily said, the CBME task force from STFM is going to come out with a lot of materials. I have a very helpful website. I think that's going to be key. And the key thing for us is to learn from each other as a community. At the Residency Leadership Summit, at the STFM National Meeting, in writing, we need to learn from others. And my request for you is always think about what society needs from us. Link what you assess to what society needs and will need in the future. Next slide, please. So this summer, we set out to say, all right, what's the baseline? What are all residencies doing right now? So those of you who are program directors, remember that we asked you, what are you doing now? And how many are you doing? And this was what we published just recently. What I'll underscore here is that it's a 92% response rate with 655 residencies that are captured here. The ones that we didn't get are mostly the ones that are new residencies and don't have outcomes yet. But I've split these up into 3 groups. The ones that most residencies are doing, that's this slide, and my next 2 slides are fewer residencies. And you'll have the actual specifics in the article I sent you, but look at what we have here. So it's no surprise to me that almost all residencies use in-training exam results and rotation evaluation results and various forms. And Likewise, interesting for me, almost all residencies are using residents to self-assess them, the first step of master of adaptive learning. Chart reviews. Interestingly for me, individual patient satisfaction are being used by most people. But what I'll score about this is that this set of assessments are probably what almost all residencies should be doing. They are reasonable. Virtually all of your peers are doing them in some form. Next slide, please. The next set are the ones that 25 to 50% residencies are using across the country. And some of them are anticipated with the new guidelines like continuity rate reports and quality of care reports. Others are being done by some places like OSCE and simulations and other things. Really striking for me that given concerns about finances, that less than half of residencies are actually giving residents feedback about billing and coding is striking to me. But what I think we need to do with these is look at these from the lens of what's actually possible for you. What do your residents need, and consider adoption of these sooner rather than later, sort of as we go forward. And then the final slide is what less than 25% residents are doing. And I think what these represent is the innovators. These are people that are doing interesting things. And the question is where and how many of these others should pick up. So I'm looking for these people to say, this is why we're doing, and this was what the yield is. And note here that there's a number of things that are really getting at what's the difference between a family physician and an APP. It is cost of care reports. It is referral analysis. It is assessments of various parts of the curriculum. So think about what we need for the future as we go forward. The big picture in this list, and the way we came up with this list was talk with a lot of program directors, say, what do you do? And we came up with a list. The big lesson is that we're already doing everything we need in the future as a community. We just need to learn from each other. Next slide, please. It's really reasonable also to say, how many assessments do we need to have? So we asked all the program directors, go through your last graduating class, which would have been June of 2023, and just count the assessments of the residents who graduated. Now, what we've learned from Canada that have been doing this for probably 10 years or more is that we're going to need many more assessments if we're going to get into the realm of trying to use these to help people learn on an ongoing basis. The Canadian numbers are somewhere between 800 and 1,000 in many of the residencies. So we said, all right, what's possible here? What are we doing? And so the median number for residencies is between 50 and 75. So I'm thinking that's roughly twice a month for a 3-year residency. We are going to need to move that up, I suspect, as we learn as a community how to do that and as residents begin asking for it. Is it going to be once a week? Is it going to be twice a week? I think we're going to learn where that's going to be. But the point is, we're probably going to need to go up. And there was a question in how to get there, and to reduce the burden of documentation is going to be key. That's why STFM is working on that app that would be digital, as well as integrating it into new innovations. And next slide, please. I think we're getting close to the end here. So the issue is, how are we as a specialty going to get there? My first comment is, think clinically. You are clinicians above all things. Think about what's really critical from a competence point of view, and adjust your rotations and your thinking about that. Don't be afraid to think as clinicians. The second is, and I think all of you realize this, is that having a shared mental model of competency is really critical across faculty. A good way of doing that is a video about a resident doing something and getting your faculty to say, is this competent? Is this not competent? And having a discussion. KrisEmily talked about optimizing the CCC function. And the key here is to continue what you're doing with milestones, which allow you to look at the developmental trajectory of residents, but then add the core outcomes, which is, are they ready for autonomous practice? Are they competent? Residency learning networks will provide, we hope that every residency in the end will be a part of this. It's all over the new guidelines. And the point is that we can learn from each other and should learn from each other. We already know the answer. And with some of you, we've talked about AIR, which is really asking a different question with a completely blank canvas. What's the best possible training for family physicians? Finally, next slide, please. So there's a question for me about how each of you on the webinar can help. Some of it is going to be in the space of developing, evaluating, reporting on new assessments. I think our organizations, STFM, AFMRD, ADFM, will continue to develop as learning communities. It's the dialogue at national meetings, but it isn't just a byproduct. That's what we're there for. We're there to learn, and it's also in writing. The ABFM is going to begin to engage the community about what we need to be working on for the 2025 assessments, and we look forward to your involvement in that. And that's going to include, just as a teaser, how do we measure practice quality? What are the core procedures that we will promise America that family docs will be able to do? What does it mean to have women's health without deliveries? How do we assess lifelong learning? So what should we be using for assessments? But probably my most important thing is have grace on yourself. Certainly the ACGME has grace. We at the ABFM have grace. This is going to take a long time. It's a 5 or 10 year journey. So with that, give yourself some time to do this and sort of open and turn it over to you, KrisEmily, and we can go from there.
All right, so thank you everybody for the attention. I know there's going to be lots of questions, so I'm gonna, these are some of the links. I know these links are going to get put into the chat. So just some of the things that I mentioned in my presentation. So the toolkit, this faculty development delivered, and then the ACGME, developing faculty competencies and assessment. So those will end up in the chat. I'm going to stop sharing my screen so that we can open up for some questions.
So we have a few, and they're all, one of them is last year at RLS, we heard that case logs might be coming to family medicine. How is this the same or different from the mobile app?
I think all of us could answer that, but maybe either KrisEmily or Mary.
Yeah, Mary, do you have a comparison for that?
Well, I don't know what changes are planned for case logs, but the mobile app is not really for tracking cases. The mobile app is for direct observations of residents in a moment based specifically on what the core outcomes are and the level of entrustability there. So it's not tied in any way to the case logs.
Yeah, I think in the end, ACGME is working on the clinical logs, and we, along with Grant Hoeksma and Lou Edgy, are really pushing them to change their system. Answering your second question here, which is, all right, how will the ACGME ensure that these are happening in programs? I mentioned how we will be revising what is in web ads and also hopefully in the residency and faculty surveys. What the RC has begun to do is to take the new standards and say, here's the data we need. The first step of it, many of you saw this summer, they looked at some of their questions and said, you know, we don't need to know what inpatient diagnoses were. That hasn't changed our practice. So you'll see changes in that, but it's not going to be overnight as we go forward.
There's a question about if a resident is not competent and requires extra time as a resource to become competent for graduation. Of course, there's always that question about the funding for that additional time and training. And I think one of the things where, certainly there's always going to be a resident that may need beyond the 3 years. But I think one of the things we're really hoping with the flexibility that's been put in place by the ACGME, particularly with that opportunity for 6 months of electives, that you are going to be able to utilize that time as a resource to enable your resident to reach their competency without having to add additional time that needs to be funded. And while that's not going to be perfect for everybody, we really are hoping that that's going to be a resource that you are able to utilize.
Well, let me comment also. In last spring, the question was raised at RLS. We'll say, won't program directors just socially promote, just to get people forward? And we think not. I really trust program directors. They're going to take it really seriously. You know that you're basically delivering your residents out to society. We are going to be working with you to try to develop protocols for what will happen. There's some models and other specialties, but we'll get more to you about that.
All right. Warren, I'm going to leave this question to you because it's specifically on the ABFM wording. This one's all you.
Yeah, and I must admit that this was actually somewhat me, but excellent patient relationships. We're looking for clinical judgment here. What we want is, our core, we are the dominant personal physicians in the United States. And most of you know that only 8 to 10% of internists are now going into general practice, depending on the measure. And that trend is rapidly happening in peds. So personal physicians, family doctors, physicians who do primary care is family medicine. And the core is the doctor-patient relationship over time. So I think all of you are trying to teach this. We'd love your assessment about that. If you think that we ought to take away the term excellent, that's interesting and we'll consider it. But thank you for the question.
Let's see here. And then another one on what the RTMS will look like next year, information as to how PGY3 residents begin to apply for boards next year. Warren, do you have thoughts on that?
So we are in the midst of actually changing the platform for RTM, and we will, I think you're actually asking about applying for boards. There will be it will look a little bit different for you coming out, but the basic function, you'll get the list of residents. You'll have to say, check off, have they completed, and then think of it as a checklist that is the next column and say, are they competent in practicing as a personal physician and each of the 5 competencies going forward. That's what it will look like. It'll look a little bit different, but it's the same basic structure. And we hope we want to make it as user-friendly as we possibly can.
Excellent. Somebody asked what evaluation platforms are programs using? Is it MyEval or others? And I think that's a question that's probably less for Warren and myself and more a question to really encourage people to share their resources. So certainly using the listservs, having conversations at conferences so that we can all learn from each other with regards to, what we're using to evaluate and assess our residents. The AIRE, I think Mary put that in the chat. And I love this from Raquel. It seems the ultimate question for program directors is at the end of residency, do you trust this resident to care for your patients without supervision? Yes. Yes, that is exactly what that question is.
And sometimes, KrisEmily, I say care for your family members. Yeah. That's what we're looking for. A little bit about what is AIR, and Mary answered this. AIR is an acronym for Advancing Innovation Residency Education. It is something that the ACGME allows residencies to do, and we've set it up so that residencies that want to do this is completely optional, can change all the rules. and say, what do they need to do to train the best possible personal physician? And Jay Fetter and others are involved with that. If you're interested in that, we'd love to talk with you about it.
Osteopathic certifying residents, how are they being assessed? The same core outcomes, yes, but in terms of board eligibility, and I don't know the answer to how that looks from the osteopathic standpoint.
I think we have many osteopathic residents that come through ABFM, and the rules are the same, whether they're MD or DO. But I can't speak to what the AOA, AOBFP is going to require. It's similar, I think, going forward, but I'll let them speak to that.
And I'd love to kind of address the EPA question again, because there's this question, are core outcomes replacing the EPAs? And I really would like to caution that they're not. The core outcomes are an outcome. Some of them do fit the very strict definition of an EPA. But I think EPAs are also things that we can continue to use as tools. The Entrustable Professional Acts, and there's a lot in the med literature about this that I, can certainly send some resources for individuals, but those can still be smaller work-based assessment tools that can be used towards assessing competence in the core outcome. So they're not completely interchangeable. So I wouldn't say they are replacing the EPAs, but the core outcomes were certainly designed in the spirit of the EPAs. So that if you're really comfortable with EPAs, you can certainly utilize that as you are working through your core outcomes. I'll leave this one for you, Warren. The abysmal data regarding U.S. health outcomes. Is there data supporting the assessment of outcomes in education and overall health outcomes for patients? Thinking that we do a good job developing family physicians in our current system, and there are other issues in the dysfunction of the U.S. health system that result in the health outcomes that we see.
Yeah, I think, of course, there are many aspects of dysfunction. What we're talking about here is how do we work on what we can control here, which is the individual physicians. So we'll go from there. And obviously working at the level of health systems, so the jobs actually allow us to do what we were trained to do, operating at the level of payers so that reimbursement will support this. All of those things we and many others are working on. But what we're talking about here is what we can train, and what we as especially have said is that we want, and this is a little bit in response to one of the shamans in the head, is we are training to full scope because we believe that, first of all, there's actually a lot of family docs that are doing full scope, lest we forget, but also family docs are like mesenchymal stem cells. They'll do what their community needs and where the jobs are. So.
Request for less of a question and more of a request that programs be made aware in advance of what web ads will look like, so programs can adjust and get good quality data, as opposed to a mad scramble.
Amen. And I will pass that on to the ACGME. There are probably some on the phone from the ACGME. Understand that they and we are engaged in a really big push on the ACGME to make it more user-friendly and to modernize the IT systems of the ACGME. And I think they want to do this, and we are going to be participating, and we hope, in a pilot to do this as we go forward. But we will let you know as soon as we possibly can. And we're also very mindful of program director and program coordinator burden here. We hope that you see dropping the inpatient diagnoses this summer as part of where we're going. We're not going to ask the question unless we can, unless it is useful for the ACGME.
Somebody was asking about family physicians are primarily outpatient. Most family physicians are outpatient only providers. Will inpatient medicine training diminish or ever leave family medicine residency training? And I would argue, as a provider who still provides inpatient care, I certainly hope not. I think we certainly have to look at the needs of our community in terms of making sure we continue to train full broad spectrum. We don't know where our residents are going to go, and they may be in inpatient. And I think it's important that we maintain that scope. That's what makes us special as a specialty. That's what, differentiates us from other specialties. So I hope that is not something that is come down the line.
Yeah, and a couple of comments. And some of you know that I started the first hospitalist program at the University of North Carolina, which is now a huge program with about 2,500 hospitalizations a year or more. This is deeply important to me personally, but more importantly to the specialty. The other point I would make to all of you, and I will present this data again at the RLS and as well as any other place, is that let's not give in to assumptions about where family docs are going. We've looked at the trends. We collect the residency graduate survey 3 years out. So we track what people are doing 3 years after residency. One of the things that's dramatically obvious is that it hasn't changed over the last 8 or 9 years. And about 55 or 60% of our residents are doing some flavor of, 35 to 40% are doing some component of inpatient medical care. It's pretty consistent. About 9 or 10% of our graduates end up as hospitalists, and an extra 25% are doing continuity care where they take care of that. And it's really hard to predict who's doing where. We have to train for our residents wherever they go.
I want to take a moment and acknowledge that we are at 1 hour. Dr. McCrory and Dr. Newton have been so generous as to clear their calendars for an extra few minutes of questions for those of you who can stay on. We will continue to record. So if you have to hop off, that recording will be emailed to you, and it will also be part of the CBME toolkit at stfm.org/CBME toolkit.
Thank you. So I want to talk about this question that came up. The line between competence and proficient can be very challenging. And I think most of us are really looking for proficiency more than competence. And will the tools help us specify competence level? I think of entrusting my patients or family to a resident's independent care as a proficiency level, not just basic competence. And I think this is where we're getting into some of the weeds of what are the definitions. So I know that I had on my slide this kind of novice, advanced beginner, competent, proficient, and expert. And those particular terms and that particular thing comes from the Dreyfus developmental model of learning. So they are very specifically defined. And I'd be happy to provide that resource for individuals who are more interested in kind of what that delineation is, because I think it's one of those things wanting to know what that operational definition is. So when I talk about competence, it really is that this resident is competent to go and provide independent care without any type of supervision. We know that when a resident comes out on the first day as an attending, it looks a little different than when you've been in practice for 10 years. You're not necessarily as efficient. You're still maybe not quite got all of that inductive reasoning down. And when we start to talk about proficiency, that's that piece we're talking about. And there are some in the med ed literature, there's a little bit of a differentiation on that. So just to kind of differentiate how that works out.
A couple points I would say is that it's really important as you work with residents, you don't stop learning when you're graduate from residency. We actually have some data that with respect to knowledge, which is only one of the competency, you're not at your highest at the end of residency. You're at your highest probably in your mid to late 40s is the first thing. And the other thing that's interesting for me, KrisEmily, is that if you look at what some of the four-year residencies are trying to do, they're trying to go beyond competence and expertise to get closer to mastery because that's what they think their communities need. And so it's an interesting frame. They want to push up the level of competency within residency.
Excellent. Will either the ACGME or ABFM ask us to report on number of evaluations per residence per year? I'm not aware of that coming down the line. I don't know, Warren, if you have heard.
But no, I think this is more for you. I think we need to reduce the burden of documentation. Some of you have used the M3 app. which is about 25 residencies, which is giving that real-time feedback to a resident, done the right way. Residents really like it. That's where we need to go, and I'm really happy that STFM is pushing getting more assessments. We will track this because I think it's a measure of our culture around formative assessment, but I don't think that's going to be a requirement.
And I'd like to really kind of add on that I think when a lot of us think about an assessment and evaluation, I think a lot of us are thinking that kind of old school 10-question Likert scale, end of rotation evaluation. And while those still might have a place, I'd like people to consider that when we're talking about increasing the quantity, like we may be looking at smaller, more focused assessment pieces that are things you do in the moment to help guide your learner along this progress. So really kind of reframing what we think an evaluation and assessment is, so that you are not just looking at those, end of rotation evaluations as well. So some assessments are going to be smaller but more frequent, as opposed to some of the larger ones that happen more periodically.
KrisEmily, let me give an example. And one of my general rules is go to Canada for many things, but Calgary for a long time has had a very simple assessment. You observe a resident, you're precepting, you're on service, you're whatever, competent, not competent. If not competent, why? And then that goes instantly to the resident and you have a discussion about it shortly thereafter. So it's feedback in the moment, very simple. And I think the best systems need to be bidirectional, so that the resident actually tells the faculty whether or not they've done a good job of giving feedback or something like that. But it's really simple in real time. You don't wait 4 weeks to look at somebody's comments. You get it in real time, because we know the sooner to real time the assessment is, the better it is for everybody and the more impact.
Excellent. Grant application funding for the 3 to 5 year AR cycle. So those without funding could participate in AIR.
Yeah,
I don't know
I think
what's.
I think we will have funding for the annual meeting. We will not be funding individual slots. I think what we've learned from the first 6 years, as many of you know, there've been a fair amount of publication about the first 6 4-year cycles. And what we've learned is that the financing, all solutions are local, but that has been something that the residencies have been able to do depending on their funding source. So we want many people to participate. Figuring out how they afford it is going to be one of the things ABFM is interested in doing, but it's a good thought.
How should we look towards the advances in AI, incorporating that into training, as well as using that for evaluating residents? I think that is an excellent question. I do not have a good answer for it, but I think that's going to be something that's, without a doubt, is going to be something that we're going to continue to see. So,
yeah, let me, I mean, we're all going to learn this. It's a great question. And let me give you 2 vignettes. One is that we have started a collaborative of large health systems about how they can develop primary care to improve population health. And there's a lot of very big systems in this program. And we said, what are your priorities for AI in the next year? And these are systems that there's a total of 12,000 family docs in these large systems, or 12,000 providers. What they say is our #1 priority is reducing the burden for family physicians. It is managing the inbox, it is prior authorizations, it is documentation. And we've actually just gotten feedback on our first 2 PI performance where people are actually using AI to drive down the inbox. And we've set up a system so that people can get credit. We want to encourage this. This feels really, really important. I think all of us are going to be working on, is it true or not what AI does? And we're going to be playing with that. And as clinicians, and certainly we in the board, all of us are working on this. So it's a great question. And I suspect you'll ask the same question a year from now.
Agreed. And then what looks like, I think our last one, how are you going to assess the competency of procedure training for family medicine, especially as there's no case log for family medicine, unlike other surgical specialties? And I think this is a really important point, that ultimately our programs are looking to create family physicians who are going to go work in their community. So what does your community need? What procedures do your residents need to be competent in your community? What is that societal need that you're looking at? And then going back to that CBM kind of mind frame, how do I assess that? How do I decide somebody can be entrusted to do this procedure? What are the knowledge pieces they need to have? What are the skill sets they need to have? What are the attitudes that they need to have? And how am I going to expect my resident to demonstrate that to me by the time they graduate? So I think there is an importance that there's not this really defined list, because what the needs are in one part of the country may look very different from the needs in another part of the country. And so again, having a little bit of that flexibility is important.
Yeah, I'll say a little bit differently, KrisEmily. People are asking about clinical log because Grant and others have said this might be out there. It still might be out there. Exactly what's under the hood. There is a need to track procedures. What I'll observe from our data is already the majority of residencies are doing this in some way. First question for us, Chris, at the board, KrisEmily, at the board is, what ones should everybody do? And we think that's important. And then there's going to be some optional, which is, what do you need to do? Do you need to do colposcopy with LEAP? And in some communities, you do need to do that. In others, you don't. But what we want to do is to try to come to more consensus about what we need to do. And that's what we're going to be doing over the next 6 months, the what, as we go forward.
Awesome. All right.
I will also comment that you all as family docs and family doc educators need to remember how the credentialing process works. I've talked with people who run primary care service lines, and given all of their all the various practitioners in their service lines, they say, should we credential for Pap smears? Not all of our primary care providers can do Pap smears. And I think most of us are shocked by that, thinking, how could you possibly be trained to be a primary care provider? All family docs are trained for that, but that's not true for all primary care providers. So let us remember basics as well.
Absolutely. I think that's all of the questions that I see in the Q&A.
Well, thank you so much, Dr. Warren and Dr. McCrory, for giving us your time and sharing your expertise with us. We so appreciate it. And thank you to our attendees who were able to hang in for an extra few minutes. Again, this recording will be part of our CBME toolkit and at stfm.org/CBME toolkit. And we hope that you enjoy the rest of your day.
Thank you, everybody.
Thank you, STFM, for this, and thank you to everybody. Great questions.
Excellent. Thank you, guys.